C. diff infections, they conjure up fear, as they should. But as you will come to learn shortly, the term infection is a misnomer here. What we're really talking about is an extreme case of dysbiosis. That's right, and I have plenty of data to back up that statement. Now, this presentation is not applicable to too many viewers. The average person doesn't even think about C. diff in their daily lives. And although they're exposed to spores on an almost daily basis, they shouldn't worry if they're healthy. There are only two small groups of people for whom this presentation has an enormous amount of relevance: those who have already had a C. diff infection and hospitals who want to cut down on C. diff infections, probably more specifically recurrence. So let's dive on in. CDI is the leading cause of antibiotic and healthcare-associated infective diarrhea in the United States. It affects approximately 500,000 patients annually in the United States. Of these, around 30,000 will die. The Centers for Disease Control identified CDI as an urgent threat, highlighting the need for immediate and aggressive action to prevent complication and recurrences of this infection. Between 20 and 35% of initial CDI patients will experience a recurrence, usually within 30 days. Of the patients who have a recurrence, up to 60% will experience subsequent recurrences. As you can see in Figure 2, the sepsis rate climbs very high with each recurrence, and in Figure 4, the costs along with it. Hospital readmission with CDI as a primary diagnosis incurs a revenue loss of almost $5,000, and the potential loss is nearly threefold higher for patients who are rehospitalized with a recurrent C. diff infection as a secondary diagnosis. So how is one little bug able to cause so much trouble? C. diff is short for Clostridioides difficile. It was previously in the genus Clostridium, but was reclassified into Clostridioides several years ago. And here you can see part of the key to understanding this bacterium. It's a spore with a very hardy set of layers. It will survive most anything you can throw at it, and it's everywhere. If you don't have C. diff in your gut now, you will tomorrow, a week from tomorrow, or a month from tomorrow. Its primary habitat is actually soil. This hardy little bugger can just stay there waiting for a host. It's found in all sorts of soil and river sediment samples, to include playgrounds. You bring it into your home in the bottom of your shoes or via your pets, which have a carriage rate of about 4%. So if your pet goes outside 25 times, then the chances are excellent that at least one of those times it will be a carrier. And it's found in all sorts of food, from green leafy vegetables to potatoes as shown here. In this European study, the C. diff positivity rate was quite high for the given samples. It will survive cooking, cleaning, you name it. You can't avoid it. It's not like the E. coli and hamburger meat recalls, because it can't germinate and cause problems outside of you. So you won't see any food recalls due to C. diff. For example, if we look at asymptomatic colonization, which is the number of people carrying around C. diff inside of them without problems, in this paper we see 51% of these long-term care subjects were C. diff positive, which is very high. 100% of them carried a toxigenic strain, more on that later. But all were asymptomatic. The C. diff wasn't doing anything bad to them. In this study, 2% of community subjects, 10% of outpatients, and 21% of inpatients were positive for carriage. 93% had a toxigenic strain, while 71% were asymptomatic. Lastly, in this paper, 1% tested positive on hospital admission, while 7% picked it up in the hospital. 75% were toxigenic, but of those, only 33% were asymptomatic. The point is that at some point, we're all a carrier, and that strain could be toxigenic, which sounds terrible, but if you're healthy, don't worry. If you're positive one week, you could be negative the next, only to be positive again the following with a different strain, as these tables show here. So, a slide ago we saw how in a hospital setting the colonization rates are higher. Let's revisit that. Therefore, if C. diff were a true infection, then you'd think the people most susceptible would be hospital workers, as that's where the dreaded hospital-acquired C. diff occurs. C. diff spores have been found in hospital samples from beds, toilets, door handles, and doctors' uniforms. But hospital staff members aren't suffering and dying from C. diff infections. Why is that? Because odds are they're generally healthy. The number one risk factor for a C. diff infection is antibiotic use. This is well recognized in the scientific literature. Other very important risk factors are PPI use, comorbidities like IBD, and age. Let's now look at these. You can see here how the risks for a C. diff infection skyrocket over the age of 65. Why is this? It is a known phenomenon that as we age, our microbiome becomes less healthy. And the health of your microbiome is the very center of C. diff infections. You can see here in this table that antibiotics and PPIs are tremendous risk factors for a CDI. Why is that? Because they both radically alter the microbiome for the worse. For more on that, you can view my presentations on both antibiotics and stomach acid blockers and their effects on the microbiome. What does this compromised microbiome look like that allows C. diff to run wild and cause all sorts of problems? Here is the microbial fingerprint for C. diff. This comes from my comprehensive meta-analysis of all relevant papers I could find. Most are healthy controls versus C. diff infection, but some aren't. They may be CDI versus asymptomatic C. diff plus, or something else. But as you can see, the data is exceptionally consistent across all measures. If you're familiar with my presentations, you'll understand this chart. But to summarize, at the bottom, we see all of the relevant taxa which comprise the microbial fingerprint for a C. diff infection. The y-axis is the count of studies, where a significant difference was found between the control and the C. diff infection cohorts. Orange indicates higher in CDI, while green is good and indicates higher in control. As you can see, these taxa follow very clear color patterns. Many of the classic opportunistic pathogens are significantly elevated in the C. diff infection gut, to include Enterococcus, E. coli, Klebsiella, Veillonella, and yes, your probiotic, Lactobacillus. For more on that, see my presentation entitled Lactobacillus Probiotics, a Dumb Idea and Those Who Are Dysbiotic. And we see classic health promoters significantly higher in the controls, which is to say, significantly reduced in C. diff infection. These great bacteria have names like Allostipes, Bifidobacterium, Carpococcus, Eubacterium, Faecalibacterium, Roseburia, and Ruminococcus. This is pretty much a who's who of good and bad in the gut. So now that you saw the key actors in C. diff, let's just take a look at the bad guys here and compare them to my data sets from my other presentations. The first column lists the keystone opportunistic pathogens in a C. diff infection, which you just saw in orange bars. Column 2 lists all the bad guys shown to be increased by antibiotic use in multiple studies. Look familiar? Column 3 lists the same but for PPIs. Interesting, no? And column 4 lists the keystone bad actors from my meta-analysis in IBD, which we established earlier. IBD, Crohn's disease and ulcerative colitis, are key risk factors for a CDI. Now you can begin to see why these are all significant risk factors. They share much of the same microbial fingerprint. Now let's take a look at 3 studies I used for my meta-analysis to give you a more granular feel of where the data comes from. Here in this Korean study, we see the columns up top. The first lists the genera, the second the healthy controls, and the third lists the CDI subjects. These are averages of abundance across 26 CDI patients and 61 healthy controls. If we take the first row, on average, the healthy controls had 0 Enterococcus in their microbiomes, whereas the CDI patients had an incredible 24% of their microbiome consisting of this just one genus. This genus is bad, and these levels are horrific. Lactobacillus had, on average, an abundance in healthy controls of 0.22%, but in CDI, it was 11 times higher at 2.46%. As for big reductions, Bifidobacterium went from 12.5 to 0.1%, a decrease of 125-fold. Ruminococcus, Eubacterium, and Faecalibacterium all went from 7-point-something% to 0. Now let's look at another study from a slightly different perspective. Again, we have the genera to the left, the second is healthy control, and the third is C. diff infection. Now we're looking at what is the percentage of CDI subjects with no detectable levels of various key health-promoting taxa. For 3 key amazing bacteria, more than half of the CDI subjects were completely missing Lactospira, Odoribacter, and the superhero of the gut, Faecalibacterium. Faecalibacterium, on average, comprises 5% of any given microbiome. And here, a full 60% of the CDI subjects had 0. Lastly, in this Italian study, we see the same pattern. And these controls aren't even healthy. These subjects are all over the age of 65. Remember that key age from earlier. And they're all in the hospital. The only difference is one group has a C. diff infection and the other does not, and has not had recent exposure to antibiotics. And still, we get marked differences. Klebsiella is 0.12% of the microbiome on average for the controls, but is 14.3% for CDI. Enterococcus is 0.27% versus 16.86%, and E. coli is 0.92% versus 10.69%. That means that on average, 42% of the collective CDI microbiome consists of these 3 proven opportunistic pathogens. If you add up the other bad guys, it's easily over 50%. So what is this very ugly microbial fingerprint actively doing in the gut to make one person possibly get sick and die while another person carrying C. diff doesn't feel a thing? Let me try to explain this process in this crazy slide. Your liver recycles and reassembles bile acids, which go on into the gallbladder awaiting signals to help with digestion. Usually people think of fat digestion when it comes to bile, but these bile acids are actually hormones and do so much more. There are 2 types of primary or initial bile acids: chenodeoxycholic acid, CDCA, and cholic acid, CA. In the liver, these are conjugated with either glycine or taurine. In a healthy microbiome, the bacteria hydrolyze or remove the amino acids from the bile acids, and then later the enzyme 7-alpha dehydroxylase converts the 2 primary bile acids into secondary ones. So, if you have C. diff spores in your gut, then it's possible that they won't germinate, and if they did, due to a more acidic pH, a good thing, and the presence of secondary bile acids, their growth and pathogenicity will be greatly diminished. When there is severe dysbiosis, this process is disturbed. What makes C. diff germinate from an inactive spore into a pathogenic nightmare? The primary bile acid, cholic acid, especially cholic acid, which is still conjugated with taurine. Everything else inhibits C. diff to one degree or another. So why is so much taurocholate, cholic acid bonded with taurine, reaching the lower GI tract where C. diff is residing and awaiting an awakening? It goes back to those 2 enzymes from earlier. In the dysbiotic gut, there is a significant reduction in the species that remove the amino acids glycine and taurine from cholic acid. But even more crucial is the second enzyme. Only a tiny fraction of the microbiota possesses the gene able to make this enzyme. Therefore, if you have too much taurocholate germinating C. diff spores and not enough secondary bile acids to inhibit it, along with a dysbiotic pH that is more basic than it should be, you're in trouble. Let's apply the critical information we just reviewed. Here we have the effects of vancomycin on the bile acid pool. Now, vancomycin is terrible for the microbiome before C. diff, thereby contributing to C. diff by driving dysbiosis. And ironically, vancomycin is the first-line antibiotic therapy for both first episode of infection and recurrent CDI. Here are the colors. White is before vancomycin and gray is after. Before, we see plenty of secondary bile acids, but after vancomycin, we see no secondary, but plenty of primary. Remember, the secondary bile acids inhibit C. diff, while the primary bile acid, cholic acid, germinates it. Now, like we established before, there are only a handful of species with the BAI-CD gene able to make the enzyme that transforms the primary bile acids into secondary, the critical choke point for C. diff. Here we see many of them. They're almost all from the amazing genus Eubacterium, although some have since been reclassified. If you recall from the microbial fingerprint chart, Eubacterium is always significantly lower in CDI versus controls, when a significant difference was found. Eubacterium isn't the only genus with this gene. Here we see 2 Clostridium species, one of which, C. scindens, is the most studied species in regards to the BAI-CD gene. Not only is C. scindens critical for converting primary bile acids to secondary, but interestingly, it also produces a tryptophan-derived antibiotic that was shown in this in vitro study to strongly inhibit C-diff as well as other bacteria. And even more interesting is that this antibacterial function is enhanced in the presence of secondary bile acids. Here we see Clostridium scindens paired with another 7-alpha hydroxylase producing bacterium. In this study, the researchers compared C-diff negative subjects to C-diff colonized non-toxigenic subjects versus C-diff colonized toxigenic subjects and C-diff infected subjects. When just looking at these two species in terms of the crucial BICD gene, the C-diff infection subjects had far less of this gene in their microbiota than the healthiest control. Even those subjects who were colonized with toxigenic strains of C. diff were perfectly fine, as we saw earlier. They had a little bit less BICD gene than the microbiota from the C. diff negative subjects, which is common finding, but they weren't sick. They had significantly more BICD gene than the C. diff infection subjects. Let's briefly touch on this topic. There is a lot of information here, and it gets quite complicated, but I just want you to walk away with a couple simple understandings. If you're healthy, you'll be fine, whether you have a toxigenic strain or not. The second point is that you'll clear it and eventually be positive again with the same strain or a different one. Let's see two quick examples. In this study of the subjects who tested positive for C. diff, 73% of them were carriers for a toxigenic strain, but yet they were all asymptomatic. Or in this study, we saw earlier highlighting a different topic, we see the same thing. What matters is your health, or more specifically, the health of your microbiome. When it comes to recurrent CDIs, everything still applies, but even more so. The microbiomes of those who suffer from a recurrent CDI are most often worse than those who don't. There are all sorts of statistics on this, but let's just say it's very prevalent, costly, and deadly. Therefore, the key is, if you're a patient who has already suffered from a CDI, you should act quickly to ensure you don't suffer from another. The statistics are very ugly if you do. If you are working in the hospital setting, you want to ensure that your initial CDI patients get better and don't soon return. As we stated in the beginning, between 20 and 35% of initial CDI patients will experience a recurrence, usually within 30 days. And we see that here in the study. Although this study went out to 90 days, just about everything happened in the first 30. In the first 14 days, 87% of the recurrences were with the original strain, whereas at days 15 to 31, after treatment, 23% were with a new strain. Either way, we need to dramatically improve the microbiome in an attempt to prevent recurrence. The best way to do this is via FMT, fecal microbiota transfer or transplant. In fact, from this review paper, when you look at Table 2, I have highlighted the many trials which compared FMT to antibiotics for the treatment of C. diff. And every time FMT won. See the column labeled most cost-effective treatment. Most of these are for a recurrent CDI. Here we have a study which seems to put everything together. This is in subjects with recurring C. diff infections with a range of 1 to 5 recurrences. Stool samples were collected from the 26 RCDI subjects pre-FMT and at 8 to 12 weeks post-FMT and compared to their 17 FMT healthy donors. When you look at A, you can see massive shifts from their pre-FMT microbiome in blue to the post in red. You see huge reductions in some of the key opportunistic pathogens we highlighted earlier, and huge increases in classic health promoters like E. rectale, F. prausnitzii, and Blauschia obium. The taxa in red print are BSH producers, which was the first enzyme we discussed earlier in the crazy bile acid metabolism graphic. When we look specifically at BSH activity, we see the donors in green had much more than the RCDI subjects before FMT in blue. But after FMT, the BSH activity became equal to the donors. Again, this means that they can once again cleave the amino acids off the cholic acid, the first step in the process. And one of those two amino acids is taurine, and it's the taurocolic acid that's the worst offender in C. diff. But you can also see how their BSH levels decrease with time. More on this shortly. And you can see the torricolate numbers plummet after FMT here, in accordance with the BSH enzyme activity we just saw. So it all lines up perfectly. And lastly, we see the BAI-CD numbers, that second and very important enzyme. Again, pre-FMT, these numbers were significantly lower than the donors, but post-FMT, the presence of this gene shot up, which signifies more ability to make the crucial 7-alpha dehydroxylase enzyme. And here we see in another FMT trial where before FMT the levels of the primary bile acids were very high, whereas after FMT the levels of the secondary bile acids were high, and the primaries were undetectable. And here we see the same thing with these RCDI subjects. The key primary acid, cholic acid, was very high pre-FMT and dropped dramatically post-FMT. And the two secondary bile acids we've been highlighting did the opposite, which is a good thing. But as we mentioned earlier, the benefits of FMT can wane over time, and we see that on our last paper for this presentation. You can see here that for a subset of these subjects, their microbiomes began to fall off a cliff at about 100 days out. Now this trial had a 90% success rate, and shown here, the taxa most correlated with success were F. prausnitzii, Roseburia, Bloescheri, Bacteroides, and Parabacteroides, while failure was correlated with Fusobacterium and the so-called probiotic Lactobacillus. For the patient, if you've had one or more C. diff infections in the past, you should act to rectify what is clearly a dysbiotic microbiome. Short of FMT, my protocol is the next best thing. It's important to drive a significant shift in the microbiome with properly blended and dosed prebiotics designed to feed the health promoters who are severely depleted in the C. diff infection microbiome. As for hospitals, it is critical to support the microbiome to avoid recurrent C. diff infections. Again, the philosophy is the same as with the patients. The only variable could be FMT. First, a proper donor needs to be chosen, one who is suited for the C. diff infection fingerprint, which is different from, say, the microbiome for weight loss or dementia or something else. Second, if FMT is administered, then data shows us that the new microbiome may not last as long as desired. The new owner may not be as health conscious as the donor. We still need to feed the health promoters to maintain the benefit for as long as possible. If you're working in the hospital setting and this presentation resonates with you, reach out by email at my website, themicrobiomeexpert.com. If you found this presentation informative, I have many more for free in my YouTube channel and also in the Microbiome University tab on my website, themicrobiomeexpert.com. There you can select from a wide variety of topics. And if you or a loved one are struggling with a disease/condition, I have condition-specific presentations as well, along with their microbiome protocols found within its respective tab on my website.